Howdy y'all, my name is Garrett Lipinski. I'm the Res to PO, and today I'll be refreshing you a little bit on obstructed airway and extremis. So obstructed airway or foreign body obstructed airway. These are relatively straightforward protocols. This is what you use whenever the patient has something lodged in their airway. So if the patient's conscious and can breathe, cough, or speak, encourage the patient to cough, to get it out on their own. Transport the patient in a sitting position. It's generally very comfortable for them. And administer supplemental oxygen. If the patient is conscious and cannot breathe, cough, or speak, then you can perform the Heimlich maneuver, which we'll cover a little bit later. And then if the patient is unconscious, remove any visible airway obstructions by hand, such as look in their mouth, use your pinky, sweep anything out, have your suction, maybe use suction to get it out, and then perform CPR. So same idea, except if it's pediatrics, a few things change. First thing that changes is when you're administering oxygen, what you might do is hold the mask about 6 to 8 inches away from the child's face. That way it's not messing with them, and it's just more relaxing for the patient. And then when you are, instead of Heimlich, you don't do the standard Heimlich maneuver on an infant. You just do 5 chest thrusts alternating with 5 back blows. Do this alternate a few times. That way it's a little bit gentler on the patient's body, on the infant's body. It still gets the same effect. And then again, if patient's unconscious, same procedure. And then the key points to consider is do not delay transport. Really want to get the patient up to a higher care. So obstructed airway, summarize for the protocols. If the patient's conscious and can breathe, encourage the patient to cough and then administer oxygen. If the patient is conscious and cannot breathe, then use the Heimlich maneuver, which we'll cover on the next slide. And the patient is unconscious, remove any visible airway obstructions and perform CPR. Finally, transport the patient, get them to that higher level of care, call MedCom to let the hospital know that you're coming, and they might advise you to do stuff along the way, and then consider an ALS intercept. ALS can intubate and help out in other ways that we cannot do. Choking. So for the Heimlich maneuver, we've all gone through this, so just real quick, what you do is have one hand in the shape of a fist, one hand in the shape of a cup, cup that fist, put that below the patient's sternum line, so right in their midsection. Kind of go in the little soft area of their belly. Whenever you do a thrust, you pull in and up. The idea is your hand is acting as the patient's diaphragm, and it's forcing the air that's in their lungs up and out to dislodge whatever's stuck in there. Or when you're standing behind the patient, don't have your feet together. Have your feet slightly spread apart, one forward, one slightly back. So if the patient falls back, your bracing can help support and lower that patient down to the ground. Once they're on the ground, again, look in their mouth. Visually pry it open, use your fingers, sweep anything that you can see out, suction if need be. Try rescue breath. If that doesn't go in, then, even if it does go in, actually, if that doesn't go in, try to suction again to get something out and just do that CPR. CPR, one's going to get that blood flowing, and also it's also compressing the lungs a little bit. So that should help dislodge anything that's stuck in there. So respiratory arrest / failure. This is, again, a respiratory issue, however, not necessarily something lodged in the patient. So your criteria for this is a patient has cyanosis, turn in blue, visible retractions, severe use of accessory muscles, etc. So this just means the patient's not getting enough air circulating through his body, enough oxygen. So what you're going to want to do is you're going to want to open up that airway using the head tilt chin lift or a jaw thrust maneuver. Remove any visible airway obstructions by hand. You can use that little finger sweep, and then suction if need be, and use the BVM. BVM gets the most oxygen, the most airflow through the patient, because you're pretty much breathing for the patient at that point by ventilating. For an adult, your BVM, the rate should be about one breath every 5 to 6 seconds. And then, whenever you do that, you want to see chest rise. So while you're doing the BVM, watch that chest for visible chest rise. Remember, you're not forcing the air into the patient. It's gentle. You're putting it in, pulling out, pull in, put out. Do not force the air into the patient. Key points: do not delay ventilations. We want to get them on right away. Everybody needs oxygen, and do not delay transport. Remember that ALS and the hospital can do a lot more than we can. So for pediatric, same general process. Initially head tilt chin lift, suctions, remove any obstructions all the way down. So same process all the way down to ventilate, except for a pediatric patient, you ventilate every 3 to 5 seconds rather than 5 to 6. And then also In the protocols, it recommends that we attach a pulse ox to the patient, monitor to keep the patient above a 94% O2 level. You can do this to an adult, however, it is in the protocols for pediatric. Same key points. Don't delay ventilations, don't delay transport. So, short and sweet, respiratory arrest. Check the criteria so you know what's going on with the patient. Call for ALS, open the airway, and then clear any obstructions and suction. Those are the two steps you use to clear that airway. BVM with supplemental O2. Remember, so for the O2, you go up to 25 liters per minute. 1 breath every 5 to 6 seconds for an adult, 3 to 5 seconds for pediatric. Airway management with adjuncts if necessary. Off to the right here, you can see the OPA and NPA. It's recommended that you put them in. You don't have to, though. Transport the patient and then call Medco. That's what we do for respiratory. Finally, our obvious signs of death. So sometimes you might be wondering, okay, when do I not have to continue patient? Pretty much always have to continue patient, except for these few criteria, which we're about to list out. So on the legal side, the patient can have a MOLST, EMOLST, or a DNR form. So the MOLST stands for Medical Orders of Life-Sustaining Treatment. EMOLST is electronic version of that. What these 3 forms pretty much state is when the patient or the patient's family has decided that they do not want the patient to be treated after a certain point. Obviously, if a patient has those forms, read them. That way you can decide what's the best course of action to take. If a patient doesn't have those forms, however, they exhibit any of the following signs, then you also do not have to treat them. So that's your body decomposition, rigor mortis, or body decomposing. Rigor mortis, that means their limbs are starting to lock up a little bit. Dependent lividity, that's where the blood starts pooling. And then injury not compatible with life. So that's decap, they're like cut in half, severe burns, etc. Also, if the patient has been submerged for greater than 1 hour. So that means like patient not scuba diving, like patient was swimming and then they went under, didn't come back up for an hour, had no air while they were down there, you can consider them dead. Whenever you do one of the above actions, you decide to discontinue care, notify law enforcement. All these situations can be very difficult legally, but having law enforcement there to back you up and ensure that you're on the correct side, it makes everything a lot simpler. So for obvious, if patient is any of the following, MOLST, EMOLST, or DNR forms, read those, follow whatever it says in those forms. If patient has body decomposition, rigor mortis, dependent lividity, injury not compatible with life, or the patient submerged for greater than 1 hour, you do not have to continue care. If you decide to like withhold resuscitations, do not continue care, then call law enforcement. That's all we have for you today. If you have any questions, please reach out to Al Corner or myself. I'm more than happy to help you out. Have a great day.